Atrial septal defect or ASD is one of the most common congenital heart diseases encountered in adulthood. While frequently asymptomatic during childhood, its long-term hemodynamic consequences demand precise anatomical and clinical differentiation. Atrial septal defects are classified based on their embryological mechanisms and anatomical locations within the interatrial septum. Ostium secundum is the most prevalent, 70 to 80%. It is in the fossa ovalis region, caused by excessive resorption of the septum primum or inadequate growth of the septum secundum. It's the most common type, amenable to percutaneous device closure if adequate tissue rims 5 mm or more exist. Ostium primum about 15%, in the lower portion of the septum adjacent to the atrioventricular walls and due to failure of the septum primum to fuse with the endocardial cushions, often associated with a cleft mitral valve or broader atrioventricular septal defects, requires surgical repair. Sinus venosus ASD about 5 to 10%, superior variety near the superior vena cava entrance and is more common, inferior variety near the inferior vena cava entrance. Strongly associated with partial anomalous pulmonary venous return, where right pulmonary veins drain into superior vena cava or right atrium. Coronary sinus variety less than 1%, located at the roof of the coronary sinus, caused by the unroofing or fenestration of the tissue separating the coronary sinus from the left atrium. Rare, causes a left to right shunt via the coronary sinus ostium. The physiological consequence of an ASD is primarily driven by a left to right shunt determined by the size of the defect and the relative compliance of the ventricles. Because the right ventricle is more compliant than the left ventricle, blood preferentially flows from the left atrium to the right atrium throughout the cardiac cycle. There is increased right atrial volume and right ventricular volume overload, right ventricular dilatation and paradoxical septal motion, flattening of interventricular septum during diastole, and there is increased pulmonary blood flow, QP, relative to the systemic blood flow, QS. The severity of the shunt is quantified using the pulmonary to systemic flow ratio. QP by QS is equal to stroke volume pulmonary divided by systemic stroke volume. Hemodynamic threshold. A ratio of QP by QS more than or equal to 1.5 indicates a hemodynamically significant shunt capable of inducing long-term right ventricular remodeling and pulmonary vascular remodeling over decades. Many patients with atrial septal defect remain asymptomatic until the third or fourth decade of life, when subtle exertional dyspnea, fatigue, or supraventricular arrhythmias prompt evaluation. A wide fixed splitting of second heart sound is the pathognomonic feature. The split is wide because of increased right ventricular stroke volume, which delays pulmonic valve closure. There is also an increase in the hangout interval due to low pulmonary vascular resistance. It is fixed because the respiratory variations in systemic venous return are equalized across the large atrial septal defect, maintaining a constant volume discrepancy between the ventricles. Systolic ejection murmur, heard best at the left upper sternal border. Note that this murmur is not caused by flow across the atrial septal defect itself, which is a low pressure, low velocity flow, but rather by increased functional volume blasting across the pulmonic valve. Mid-diastolic rumble, heard at the lower left sternal border in large shunts, that is QP by QS more than 2, representing increased tricuspid valve flow. ECG findings may vary by anatomical type. Ostium secundum, right axis deviation, incomplete or complete right bundle branch block due to right ventricular volume overload. Look for the cross-attached sign, a specific notch near the apex of the R wave in inferior leads that correlates with shunt size. Ostium primum, characterized by a left axis deviation due to early activation of the posterobasal LV wall alongside an RBBV pattern. Echocardiography is the diagnostic gold standard. Transthoracic echocardiography evaluates right ventricular enlargement, paradoxical septal motion, and estimates pulmonary artery systolic pressure. Color Doppler visualizes the transatrial flow. Agitated saline contrast, that is the bubble study, evaluates right to left or transient bidirectional shunt, bubbles appearing in the left atrium within 1 to 3 beats. Transesophageal echocardiography, essential for checking the precise anatomy of the defect, mapping out the superior, inferior and aortic as well as the posterior rims, and ruling out anomalous pulmonary venous connections prior to intervention. Asymptomatic small defects with QP by QS less than 1.5 without evidence of right ventricular enlargement or pulmonary hypertension generally do not require closure and can be monitored clinically. Indications for closure: right ventricular enlargement, that is volume overload on echocardiography regardless of symptoms. Hemodynamically significant shunt, QP by QS 1.5 or more. History of paradoxical embolism, that is cryptogenic stroke. Documented orthodeoxia platypnea syndrome. Percutaneous device closure is the treatment of choice for ostium secundum defects. It requires a circumferential tissue rim of at least 5 mm, except for the deficient anterior or aortic rim, which can often be accommodated by modern occluders to safely anchor the device. Surgical repair is mandatory for ostium primum, sinus venosus and coronary sinus defects or secundum defects lacking adequate anatomical rims. It involves patch closure using autologous pericardium or synthetic material and concurrent redirection of anomalous pulmonary veins if PAPVR is present. Interventional management has also been described in some cases of superior sinus venosus ASD recently. If a large ASD is left untreated for decades, severe irreversible pulmonary vascular disease can develop. When pulmonary vascular resistance rises to systemic levels, the shunt reverses to a right to left shunt, leading to cyanosis, clubbing and erythrocytosis. Once Eisenmenger syndrome is established and fixed pulmonary hypertension is confirmed, that is pulmonary vascular resistance more than 5 Wood units that doesn't respond to vasodilators, closure of defect is strictly contraindicated, as the defect now functions as a vital pop-off valve for the failing right ventricle.